Just wanted, excuse me, just wanted to thank Brian for putting together this conference. So I was tasked with coming up with basically what a tendon is. So I'm going to go through a little bit of basic tendon anatomy, and then what is a tendon made of, and a little bit of the biochemistry. I think we all know about the upper extremity anatomy of this. So I thought, in researching this topic, I thought, well, what are the named tendons? And I can only come up with one, and it's one we all know, and it's the Achilles tendon. Here you see, it's basically the only named tendon that exists. And here you see Achilles with his one weak spot, which was the Achilles tendon. And it's not surprising because it's the strongest tendon in the body and the largest, and it can bear loads in excess of 3,500 newtons or 786 pounds. And despite all of this, it's still one of the most frequently injured tendons, which you see here, a repair of the tendon. In all of our flexor tendon repairs, you can look at the stitch work here. It's a huge number of passing sutures through this because of the strength required to repair this type of injury. And on top of that, if you contrast this with our upper extremity tendons, here we go, so we found this. So I found this on the internet, and it's the only video I could place into a talk that actually worked. But you see all these small tendons coming through the carpal tunnel here, and it's amazing that we don't have more problems with carpal tunnel because you have these upper extremity tendons all coming through this one little area, and you want this all to function independently and together. So I thought that was pretty impressive. So I want to go through basic tendon anatomy and biology, and go through the overall structure, proceeding from the emphasis to the myotendinous junction, that's what those are, and then composition, so the chemical composition of tendon, a little bit about the cell biology, and then some of the material properties, what allows tendons to behave the way they do, and how can we sort of match those in our repairs. A little bit about the blood supply, and then some of the tendon injuries and healing, and what to expect. A little bit of overlap here, but so when you go through the embryology of the tendon, you can't discuss anatomy without first talking about embryology. And there wasn't much on it. We know a little bit about the development of the upper extremity, and here you see the upper limb bud that comes at about stage 14. And it's delineated with distal, anterior, posterior, proximal portions. And about over the last 20 or 30 years, we've described this apical ectodermal ridge that produces out growth factors and genes, some of which you see here, the HOX, FGF8, and the sonic hedgehog gene. And some of these, are turned off and upregulated or downregulated at different times, and that causes a little bit of the changes that you start seeing in the limb bud. But no one has really described why, certain areas become a thumb versus, certain areas become a long finger. But here at 51 days, you basically have, your hand that has been formed, and most recently, scleraxis, which is a transcriptional activator of immunomodulin, has been described, and this shows some of the earliest images of mouse forelimb development, and this is very specific for mature tenocytes. So these tenocytes are the ones that form tendon, and it's just an early depiction of the formation of tendons. And one of the things with embryology of tendon, it has to be under a little bit of tension. So what is true embryologically turns out being true for the rest of your life, and you have to kind of use it or lose it. So So it has to be under a little bit of tension in order for the tendon to develop as you would hope. So grossly, looking at what a tendon does. So a tendon attaches muscle to bone, and the emphasis is the point of insertion at the level of the bone. On one side, then you have your tendon, and then on the other side, you have the myotendinous junction. And why are these regions important? This is showing a microscopic area of the Achilles tendon, and there are all these little fibers and that go from the tendon into the bone, and there's this gradual transition from the tendon and ligament into the bone, which you see here, and there's all sorts of different types of collagen and fibroblasts at one level, at the level of the tendon, and then as it goes over, as it sort of blends into the bone, you have different types of collagen that we described for this, and so that the attachment is very kind of smooth transition. But even with that, there's a lot of tension at this level, at the emphasis. And this is where you get enthesitis, and there's a whole series of problems that we've touched on a little bit today with some of the other talks, like lateral epicondylitis and other upper extremity problems. This is you have recurrent stress at the level of the digits, and it's associated with the HLA-B27 arthropathies and ankylosing spondylitis and psoriatic arthritis. And there's a whole field in rheumatology describing this. And basically, that's just the attachment of where the tendon is to the bone. Proceeding through the tendon and then to the musculotendinous junction, the musculotendinous junction is considered the growth plate of the muscle, and it's also where the most you're most likely to get a torn area as a result of excess stress of the musculotendinous junction. Then going here, there's a sequential order of collagen molecules to the endotenon, collagen fibers, and collagen fascicles. All of these form together to form a tendon. And over here is where you see, this is basically what we're repairing when we repair a tendon. So the epitenon and all of these sequential hierarchy of small fibers all oriented in a similar direction. And that's what we see. So what are we seeing when we look at tendons? Basically, what is the composition? What you're looking at is basically type 1 collagen. So there's been a lot of biochemical studies to look at what the composition of tendon is. And you have collagen types 1 and 3 are the most common. You have these things called proteoglycans, which you have decaran, hypercan, quercecan, and lumican, and probably 10 others that are less described. And then you have tenocytes and fibroblasts, sort of a low concentration of tenocytes, which is why the metabolic demand of a tendon graft is so low, which is probably why it does survive when we do tendon grafts. And then you have a mixed bag of lipids and non-collagen proteins and elastin. And this kind of shows it a little bit better. Between your type 1 collagen and your type 3 collagen, it's over 90% of what you're seeing when you look at a tendon. So what is collagen? So collagen is type 1 collagen is a protein that makes up 85 to 95% of the tendon. It's the most abundant collagen in the body, and it's encoded for by the COL1A1 gene. And the other type of collagen involved here is type 3 collagen. It makes up about 5%. Type 3 collagen, we'll talk about it a little bit later, but that comes in kind of as the rescue collagen. It's in the acute phase, that's sort of upregulated a little bit more than in normal tendon, and you get a little bit of type 3 collagen to help the healing initially. And then as time goes on, it goes back to its normal amount, type of collagen takes over again. This just shows kind of the hierarchical organization of this. You have a triple-stranded collagen molecule, and that forms collagen fibrils. And if you had any, there are some diseases that are associated with a defect in this collagen, type 1, and Ehlers-Danlos syndrome is pretty common. That's one of the most well-known ones. Osteogenesis imperfecta, which is involved with more bony structure. And of course, vitamin C deficiency, scurvy. But Ehlers-Danlos syndrome comes into play with a lack of collagen. Many different types, loose joints, dislocations, chronic pain, and without vitamin C, wound problems. And this is then going back to type 3 collagen. Once again, this is coded for by the COL3A1 gene, and it's basically in the acute injury phase. So then moving on to the proteoglycans. So these are about 0 to 5% of the weight of tendons. And these are also proteins that are covalently bonded to glycosaminoglycans. And decorin is the most predominant one that has been described. And this schematic drawing hasn't really changed in about 20 or 30 years for keratin sulfate, hyaluronidase, and proteoglycan. And if you think about these, what's been discovered more recently is that decorin kind of regulates collagen fiber diameter, and it forms crosslinks between collagen, allowing them to slide together a little bit. This will help with some of the viscoelastic properties of tendon that we see, which is why we may overcorrect or repair these a little bit. Aggrecan provides tendon with a high capacity to resist compressive forces and tensile forces associated with loading and mobilization. So a lot of these small, even though it's a small amount within the tendon, plays a large role in terms of how tendons heal and basically how they put together. And the way to think of it is collagen is sort of the structural element that creates tendon and builds these buildings. And the proteoglycans of that are sort of the molecules that allow the interaction to occur and to slide together a little bit and give those viscoelastic properties to tendon. The predominant cell type are fibroblasts. And basically, it's fibroblasts and tenocytes. Both of these, they're in a low proportion to collagen, but these are the cells responsible for manufacturing the collagen within the tendon. And then going on to, all of this works together to create the material properties of tendon. And basically, they're viscoelastic. So if you think about an elastic structure like a rubber band, a purely elastic material, the force displacement relationship does not depend on the velocity of stretch or time held and the length of the load. Whereas a viscoelastic material, it does depend on that. So one way to think of this is memory foams, mozzarella cheese, and human skin. So when you stretch it out, it sort of slowly comes back to where it started. So the other way to think of it is a piece of silly putty. And I think the therapists, we use putty all the time. And if you stretch it really quickly, it snaps. And if you stretch it slowly, it just sort of stretches. So this is maybe one of the reasons why Achilles tendon will snap, even though it's a very strong tendon. If you got a quick force on it, it'll rupture. And the two engineering topics there are creep and stress relaxation, which you can see here over time. Tissue creep with constant load, and stress relaxation with constant tissue length. All of these factors and the mechanical properties of tendons will change over time. So with age, gender, stretching, training, and fatigue, the properties, the viscoelastic properties of tendon will change over time. And these are things we all have to keep in mind when we're choosing the sutures that we use to repair tendon. I think the fiber wire has a little bit of viscoelastic property to it, which may help match the properties of tendon a little bit more than what we like traditionally use, which is braided down. And going on to the blood supply, basically there are three major areas of blood supply. You have blood supply to the tendon comes from the musculotendinous junction, the osteotendinous junction, and the vincula. And going back to Dr. Davenport's talk and Dr. Simpson, when you think about zone 2 injuries, you can see right here in the center of this diagram, that's your zone 2 injury. You're disrupting the vincula and you're disrupting the tendon right where it goes, has to really weave its way through the tendons, and that's going to cause all the problems in that time. But it also it also shows you maybe why tendon grafts work. There's such a low metabolic demand of tendon that you can reattach, basically put a tendon graft in without any kind of blood supply attached to it, and it will work. So moving on to just kind of a brief overview of tendon healing. You have inflammation at 1 to 7 days. Fibroblasts are producing that type 3 collagen initially, and macrophages help initiate healing. And then you have a reparative phase at 7 to 21 days. Tissue modeling with large amounts of disorganized collagen and angiogenesis. And then remodeling at up to 18 months, where you have type 3 collagen being replaced once again with that type 3 collagen. And strength following repair, this is just sort of a general overview. The tendon repairs are weakest at about 7 to 10 days. Most of your strength is regained by 21 to 28 days, and your maximal strength is about 6 months. Early mobilization is a way to kind of reduce the amount of adhesion formation, but decrease tendon repair strength. It's probably more beneficial for flexor tendon healing than this adhesion formation. And some of the factors affecting tendon healing and adhesion is your surgical technique, which we touched on a little bit earlier, and post-operative motion with passive and active